Ventilator, no face. Okay, servo. To turn the servo on is a mystery.
The slide over.
Yeah, you gotta slide back here, and there's a little slide over to actually get power to the unit. Once you do that, then it'll come up on the screen, it'll say servo I. Go through its little testing. And then it's going to say, do you want to start pre-use check? And if it's in between a patient and you need to calibrate it, then you need to say yes. If for some reason you had it off in a patient's room, where normally you wouldn't, you would just put it on standby, but you could say no. But our pre-use check is our calibration in between patients. So we're going to say yes. And then it's going to go over to our pre-use check, and it's going to say internal test running. Pass, and now it's going to say connect the test tube between the inspiratory outlet and expiratory outlet. That's not the bend circuit. That is the tube down in the drawer, which you have to push in to open. It doesn't open any other way. And then what you're going to do is take it and put it between inspiratory and expiratory. So we'll just unhook here and here. And go like that. Like that. Okay? Once you do that, you hit OK. It's going to keep going. And then you won't unhook that until it tells you to. And then it's going to run through its test, so it's checking its gas supply. As long as you have your O2 and your air hooked up, you won't have any problems unless there's a problem. And then it's going to run through all its different tests. If it wants you to do something, it'll tell you this is one of the easiest test out procedures on any of the ventilators. It's the servo. Yes, thank you. I'm welcome you. No. Now Jerry's going to stop me. Safety valve, remember that's the valve that will do what? What does a safety valve do, folks? I told you guys when we went over the PP.
Protect.
It will open.
Open it to like room air.
Yes, it will open it to room air. If there's some kind of malfunction, it will open the valves to room air so the patient can breathe.
Where is it at?
It's internal. It's gonna, and it's usually out the side. On this one, it's over here.
Okay. Does every vet have one of those?
Some kind of safety valve, yeah.
So this is why we did it. I asked for a cake for Christmas.
That's not going to help or work if your patient isn't taking spontaneous breaths.
No, if they're not, but it is just a safety feature. If something goes wrong internally, that the patient has a way to get air. Otherwise, they're sucking from a ventilator that's not doing anything.
How long does it usually take?
At the most, it's quicker than the PV.
So what's that first check for the tubes called? With that tube from the drawer?
It said connect test tube from inspiratory outlet to expiratory outlet.
It's internal.
Well, it has a place that has to go out to room air, so here it's on this one. It's different on everybody. It's not important to know where it's at, it's just important to know that it's there.
Sorry to say, every vet has a safety valve.
Some kind of safety valve, yes. Not important to know where it is, it's important to know why it's there. Okay, so now it says please unplug power cord. Make sure you unplug the right one. Then it's going to say please reinsert power cord. Yeah, well, there's not a red right there, so. Connect patient circuit and black Y piece, so now we can unhook our test tube. You will not need it anymore, so you can put it away. If you don't do the test tube, you guys, it will not pass the calibration. So it's important to make sure you remember that you need that. Connect patient circuit and black Y piece. So we're gonna do that and hit okay. And it doesn't like what we've done, so it's gonna ask us to redo it. These connections, patient circuit and expiratory cassette. Let's see if something's not.
Maybe a bad circuit. There was one.
Oh, well, it's
remember?
not hooked up. No, it came loose.
There was one though.
No, sometimes it's, remember we even had problems with the PV, so my thing was it was loose from the inspiratory side on the humidifier, so. This is the patient circuit test, so it's looking for a leak, and it sensed the leak because my thing had become undone. Oh.
Some tape.
No.
Stand up here.
Okay,
Oh, yeah,
that
it's
fixes
good. It's back to go.
everything.
Paper clip. Some gum wrapper. Thank you. See if it works.
Well, it doesn't like something here.
Figure it out.
Uh-oh.
Doctor. It's because Ann put it together.
No, it's.
It wasn't.
It was me. Dr. Benin.
No, it's all right.
Oh yeah, I'm here to hot mess today. I know it. She's aware. I just pull it back.
Just gonna be there.
Yeah. I'm gonna take my little.
Mine was okay.
Which one?
I didn't do my hair this morning. That looks okay to me.
I want to say.
What?
You want to buy it?
I'll find the back of it. I've been using it, and it takes me 2 seconds. But it was going to, but I have thick hair that tends to hold shade. Again.
Okay, one other thing, you guys, this is I was going to show you anyways. If you, right here, there's a little thing you can pull. You pull it towards you, and this pulls out. This is the expiratory cassette. This is where the expiratory valve is on this ventilator. So sometimes, don't worry, it won't bite. So sometimes you just take it out, pop it back in. If it's not secured in, it won't pass this part.
You just check and make sure.
Your,
it's secure.
Yeah.
Kind of like we
Troubleshoot.
said,
wires popped out.
It's because I unhooked them.
how many different kind of ventilators are there? It's like 12, like
4.
what?
I mean, well, I mean, all over the country, there's tons of them, but there's 4 main ones that are used in this area. The ones that we have here.
So the Servo, the PD 840,
Drager.
Dragon
Galileo.
Galileo.
Yep.
Fisher Price.
what's your favorite?
Fisher Price.
I don't know that I have one, because I know them all now. Typically your favorite one becomes the one you know the best, so.
I don't like.
Gonna have to.
Okay, so now we passed. So I just took the expiratory cassette out and put it back in.
So if
No.
it happens on our final, and for whatever reason,
As long as I see that you are doing everything right, you won't fail. If you're, sometimes people do something wrong though, and that's why you're failing, so I'll be watching. Okay, so now it says, do you wish to compensate for compressible volume? That's compensating, remember I told you about how compliant the circuit is, how easy it is to get the air through it. So you always want to say yes. Now we've all passed,
yay!
okay? And you said, okay.
What was that? Do you want to compensate for
For
what?
compressible volume, that's testing the compliance of the circuit. And it will then compensate for how compliant our circuit is to get the air, how stretchy this is.
But now in a clinical setting, because you removed it from the unification,
Normally you wouldn't do that.
so what would have, oh, it would
You'd have to probably change everything out.
Okay.
Would I compensate that on all of them or is it just on?
They all compensate, but they all have a different way to do it. This is how the Servo does it.
Oh, okay, but when all of them ask you, do you want to compensate? Or is it just?
The only one that says it this way is this one. They all ask differently.
Oh.
So this one says, do you want to compensate for compressible volume? And that's compensating for the compliance of the circuit. Some of them just automatically do it and don't ask you if you want to do it. So it just depends. So I'm going to hook my humidifier back up. This is asking me, do you want to delete patient data trends and event log? We don't really use that, so I'm just going to say no. And you'll see here on the front there it says pre-use check, passed, patient circuit test passed. Patient circuit test is part of the pre-use check. So because we just did a pre-use check, it says we passed both. The patient circuit test is the one that was checking for the leaks that I had to fiddle with. If you are in your patient's room and you have to change the circuit or you think something's not right, you can do the patient circuit test by itself by hitting patient circuit test without having to go through the whole pre-use. So if you see something, you think something's wrong, you change your circuit, then do a patient circuit test to make sure it passes before you put it back on the patient, because it'll test for
Anytime you
leaks.
change a circuit for whatever
Mhm.
reason, you need to like test that circuit
Yes.
with the machine.
Absolutely. And then if you want to, you can go ahead and set some preliminary settings here. See this little picture up here? This is a baby. If you see this right here, it's in baby mode, it's in infant mode. If you start ventilation, it's not going to let you go above a certain tidal volume because it thinks you're in an infant mode. So it's very important that you make sure you are in adult mode for our class. Adult. Accept calculated compressible volume after patient category change. If you had a neonatal circuit on there, your compliance would be a lot different because it's a lot smaller. We had an adult circuit on there when we did it, so we don't have to redo it. So we can say, yes, we want to keep the same data we had. Otherwise, if you changed your circuits and changed your adult to adult mode, you would have to redo the compliance. Does that make sense?
Yeah.
Okay,
See when you change the adult settings?
right there,
Okay.
adult.
Is the tubing different for a baby?
Yeah, it's a lot
Oh,
smaller.
okay.
It's a lot thinner, so it's not as compliant because it's so much thinner. So here, if you wanted to set some things before you actually turned it on, up there where it says volume control, it could say volume control, pressure control, SIMV, that's the actual mode, but that's the button you put to actually get to where all the settings are. So here you can see we can do tidal volume, respiratory rate, PEEP, FiO2, I to E ratio. T-pause is typically going to be at 0. Some people leave it at 10%, but that's basically putting an inspiratory hold on every breath, and we don't do that. So that should be on 0. Inspiratory rise time, you can leave it at where it defaults. It has to do with how quickly it gets to the set pressure or volume.
Does that associate with the minute ventilation? Does that associate itself with minute ventilation?
The rise time has to do with how quickly it gets to the set volume or pressure. So either can go quickly or slower, which would just be have to do with the speed with it gets into the patient, that big initial burst. It's more of a comfort thing. And then trigger flow. If you see positive, you're in flow trigger. If you see negative, you're in pressure trigger. Typically for the servo, they'd like you to see it in the green, which is about 5.
5 is alive. For what is that? For trigger flow?
Yeah. Remember, that's the flow going, what trigger sensitivity is. Flow trigger, we have flow trigger and pressure trigger, which we'll talk about this more, but flow trigger, you have flow going through the circuit when the patient is exhaling. And so if the patient wants to take a breath, it will sense a drop in that flow because if we have this hooked up to our ET tube, and we have flow going through here, our patient initiates a breath, it will pull some of that flow because there's a constant flow in there. The ventilator senses that the patient took some of that flow out of there and realizes that he's trying to initiate a breath, it'll kick in.
So if it was pressure control, it would be a negative.
Right.
Yeah.
If it was pressure triggered, it would be a negative, and the patient has to put all the way back through the circuit, -2 or -1, depending on what you have it set at to get a breath. Flow trigger is a lot more comfortable.
Sensitive?
More sensitive, it's more comfortable for our patients, and it's easier because they have a little bit of flow right there. They don't have to wait to get, it might seem instantaneous to us, but think about if you're hooked up to this ventilator and you have to get a breath from all the way back of the ventilator, there's no flow in here whatsoever, and you have to wait till the ventilator delivers it, as opposed to having some flow in the circuit and getting some right away. So that makes it more comfortable for the patient. I've had some people relate it to drinking a milkshake. When you drink a milkshake, the first time you go to put your straw in there, you have to suck real hard to get it out, right? But then once you start it, you have a little bit of the milkshake already in the straw, and it's easier. Same concept with flow triggering versus pressure triggering. Pressure triggering is we're having nothing in our straw at all. Flow triggering, we have a little bit in there to help get things started. So it's the preferred method, and that's what everybody uses today. So I tell you that. Every vent on how it's set is a little bit different. On the Servo, it's some have lower numbers, some have higher numbers. So just remember for now on the Servo, you want to see the green. And if you turn the dial, you'll see it go negative. Now you know it's a pressure trigger. Question?
Does that ever fluctuate based on patient, or is it just based on the circuit and the?
No, you might have to change it because your patient might be too sensitive or not sensitive enough for them. So that's a therapist adjustment. You'll have to see if your patient is auto-cycling or if he's really having to pull back to get a breath. You'll visibly see him.
Or if you want to kind of force them to do a little work.
But you gotta be careful because you can make it too hard and they'll get tired out. So usually 5 is a good place to be at. And then, based on what you said here, you will see your inspiratory time here in this little box, your minute ventilation and your flow. This is based on the values that you've set. So if your patient doesn't breathe at all on his own, these are the numbers that you'll get. I tell you that because if your patient is triggering above what you set, the numbers here will be different than what's actually reading out on the ventilator. Because that's based on 500 and a rate of 15, patient not doing anything at all.
So that's what you want them to do, but in the patient, what's the
They're
patient doing?
actually doing, right, this is our set parameters. So yeah, remember when we're talking about our different areas, this is where we set our parameters. Remember too, very important, besides for these values here,
It's gonna be.
I'll show you in another screen. This is set parameters only right here. Remember, 4 sections to a ventilator, this is where we set the parameters.
Is that V with a dot over it?
V with the dot over it is always flow. Remember, 2, 3 very important settings on a ventilator that we are in control of and we manipulate with our settings that we set. I time, I to E ratio, and flow. I time, I to E ratio, and flow. They're all interrelated. Flow is like the speed of your car. How fast is the breath going to get in? If you have your flow at 20, think of like you're driving 20 miles an hour. It's going to take forever to get to San Francisco if you drive 20 miles an hour. But if we drive 80, we'll get there a lot quicker. Flow is the exact same way. If you put your flow at 80, your breath will get into your patient a lot quicker. So hence, your I time will decrease. Because we've just said, hey, use a flow of 80 as opposed to a flow of 60. So all those settings are very much interrelated, and you have to know that when you change one, you're going to affect another. Does that make sense?
Yeah.
Okay.
What did you think is going to increase as you?
When you increase your flow, you're going to decrease your I time because you
It's getting there
increase the
quicker.
speed. It's going to get in there quicker. It won't take as long. And just as a note, that's a very common thing we'll do if someone is having trouble with exhale time and air trapping. You want to decrease the I time so they have more time to exhale. But that's, of course, we'll talk about as we go on. All right. So if you want to change the mode that you're in, you hit that very top one. Select ventilation mode. We have volume control. That's AC/VC. Same thing as assist control, volume control. Pressure control is assist control, pressure control. PRVC, AC, PRVC. Remember, for AC and SINV, we have AC/VC, AC/PC, AC/PRVC. And then we have SINV volume control, SINV pressure control, everyone.
Huh?
You're like, oh.
We're gonna go through that pretty quick.
Oh, yeah. Remember, I'm just showing you where everything is, you guys. We have a whole nother lecture on the modes in depth again coming up. But you have to know where they are on the ventilators.
At least 75.
Some of them are 100.
Yes, CPAP. I know CPAP. What's
Pressure support.
Pressure support. Now with the PSC and the CPAP, is that the mode that you use when you would want to start weaning the
Yes,
extubate?
exactly. Volume support, we'll talk about later, but it's like pressure support, where you say, I want a set volume, and the ventilator will automatically adjust the pressure support to get that patient's volume. So don't worry about that so much right now. And then we have SIMV volume control, SIMV pressure control, and SIMV PRVC. Bi-vent, later. That's a specialized mode of ventilation. It's like that APRV. Hold for a long time, go down. Back up and hold like we use in the ARDS patients for oxygenation. But we won't get to that until way later. So that's where you can change your modes. And if you change your mode, of course, you're going to change what settings you have here, because now we have tidal volume. If we went to pressure control, we'd have a set pressure instead. So we'll say accept. Quick knobs down here, you can change quickly without going there. The FiO2, the peak, the rate, and the tidal volume. Just by turning the dial. You can't change the mode with actually going into the modes up here, where the mode is. All right? To actually start ventilation, you have to press the button where the little orange light is. Until you do that, you're not doing anything for your patient.
Another power button.
No.
She didn't tell me, she said, press button. I'm like, no, turn it off.
Good present. One thing I mentioned on the PB, but our plastic lungs like to auto cycle because the ventilator thinks that they're triggering, so we turn this all the way to -20, only while it's on the plastic lung. We would never put that on a patient. And it'll give us a real reading now. It's not capnography because we don't have a patient on it. This is the waveforms. Pressure waveform, flow waveform, volume waveform. So over here, so this is where we set our set parameters. Now that same box we had when we were in our standby mode, we have up here. So if we want to change it while we're on our patient, you just go to the same section. Hit accept or else it won't do anything. If you just cancel out, it won't take any changes that you make. So you got to hit accept. Then again, we still have our quick settings down there if we want to change. Then this is our patient parameters. If you hit additional values, it'll take you to the rest. So we have P peak, remember that's the same as PIP. P mean is mean airway pressure peak. These are our actual readings. Respiratory rate, FiO2. Now here's where we have our actual I to E ratio. We have where we set it, what's our patient actually doing.
So would you say it's the same thing as
P peak is PIP.
Oh.
Then our minute ventilation, inspiratory tidal volume, and expiratory tidal volume. Additional values, you can see more. This is where you get your plateau, inspiratory time. Not so much as important. Inhale minute ventilation, exhale minute ventilation. You don't really use those. Next one is where you'll see your compliance. PEEP total, that's where you would get a reading if your patient had any auto PEEP. This is where it's actually telling you the real PEEP reading. So maybe we have our set PEEP at 5 and our patient has 3 of auto PEEP, that would be 8 there.
The auto peak is like their own.
That's the air trapping. Patient's not exhaling and it has air trapping, like a COPD patient or asthmatic.
So then we need to decrease our P.
No, don't worry. We'll talk about that a lot more later. So to do plateaus on this one, you guys, which we need for our resistance and our compliance, you have to do an inspiratory hold and an expiratory hold, which are down here. You need to be on your additional values where you see the word plateau or you'll miss it. So remember, when we do our plateaus, we inspiratory hold, see you got your plateau, go right to expiratory hold. It says expiratory hold active, next page, and then you'll get your compliance reading. So this one's a little tricky, you guys will have to practice.
You go one to the other.
So are they both the plateaus of inspiratory and expiratory plateaus?
Expiratory is not a plateau, really.
It's
It's just
a reading.
expiratory hold, yeah.
Can you show us one more time?
So patient starts to take a breath, you do your inspiratory hold. You get over to your plateau screen, expiratory hold, then go to next page and you'll get your compliance reading.
Did you hold it until you got back where you wanted, or is it like 30 seconds you want to hold it for?
You can't hold it too long. Sometimes it won't read, and so I wouldn't hold it more than 5 or 6 seconds because you're doing an inspiratory hold on your patient while you're doing that.
So is that giving you your actual lung compliance?
Mhm.
So you can tell over several days or hours or whatever if your patient's compliance is changing?
Yeah.
Do all ventilators do that, or?
Is there a amount of-
That's really kind of cool.
Yes.
Is there, like, how am I trying to face this? How often can you do that?
Usually you do it with every check.
With every check? Okay, because say for example, you want to really monitor it, it wouldn't hurt to keep doing it repeatedly, or not like.
I wouldn't
obviously-
think you won't see changes that quick.
Okay.
Every 2 to 4 hours is plenty of time. And then you can look back on previous vent checks if you want to look and see where it was before as opposed to where it is now. If you're worried about your patient's lung compliance, like an ARDS patient, getting worse or getting better. So, and then additional settings over here. You can see your I to E ratio again, if you want to change those. And again, this depends on the modes, you guys, on what you can see where, but we're in volume control right now. So just know that this isn't, and then this is, you could also change your trigger there. Alarms, here. High pressure automatically does low pressure 10 below, so you don't have to set it. Minute ventilation, high and low, respiratory rate, high and low, and expiratory pressure is our PEEP, high and low PEEP. So you'll set those. You only have an apnea alarm on this vent, you guys, if you have a patient in a spontaneous mode. So right now we're in assist control, you're not even going to have an apnea backup setting. Because the ventilator knows that it's in assist control, it doesn't need one.
Which is spontaneous.
Pressure support, or SIV. And then trends, if you wanted to see trends, you could see them here, and you could see where your patient had been trending over a certain amount of time. You see this is 24 hours, you can set it wherever you want. This is just some FYI stuff for you guys. Quick access, suction support. Suction support is a nice feature on this ventilator, and here's why. We do have O2 breaths down here, and that's when our patient will get 100%. Yes, when you suction patient, you're going to do O2 breaths right here. You'll get 100% for 2 minutes. Suction support, though, actually, see what happens? When you unhook someone from the vent, you have this air going through here all the time. When you do suction support and hit accept, it stops that. So if you need to change something, change a circuit, change a filter, this keeps you from spraying you or your nurse or your partner with all the water in the circuit. Completely stops the flow. There's nothing going on while this is happening.
For how long?
60 seconds.
Oh.
And then as soon as you back up, it'll start again.
Where do you go again?
Which button?
Quick access, and then you hit cancel when you're done. Suction support, accept, and then hit cancel when you're done. So we don't really use that for suctioning. We use that if we're going to change a filter or something like that to stop the flow through the circuit.
I was gonna say, so anytime you change any
Quick access.
components of the
And then
circuit.
Yeah.
suction
use that.
support. And then
Otherwise, use O2 breaths because that actually goes to 100%. The other thing in quick access is where you can get to your loops. This is where you guys get to your waveforms on this ventilator. So loops, waveform, scales, configuration, open lung tool, we're not going to talk about right now. If you wanted to have them up on the screen while you're actually ventilating, that's where you would do that. If you want them to go away, then you hit close. Menu, alarm profile and history. You can look back and see what alarms have been going on. Review, that's where you can see trends. Options, CO2 calibration. We don't have it in line right now, so I'm not going to do that. Compensate, if you wanted to compensate for your compliance again for some reason, you can do it there. Copy, we're not going to copy any data. This is for biomed. I'm not going to worry about that one. Panel lock, we don't want to lock it, but we just did. So you see locked, press main screen. I don't know how to get out of it. See, that's why I don't even touch those buttons. They were good now. Now I unlocked it. And then